Hi, thanks for tuning in. My name is Luke Vayo. I'm a senior biology major. Today I'll be presenting on a paper I'm writing for my capstone class for my biology major called Impact and Prevention of Racial Bias for Medical Providers, a Review. Just a little piece of context on this. So I'm still in the process of writing this paper, so this is just meant as sort of a snapshot of the work I've done so far, with just some of the big takeaways from the research I've read up to this point, and for the sake of time I'll just be going over kind of the biggest findings and the major takeaways so far. So the objective of this paper was to essentially summarize the existing research on racial bias on the part of medical providers, just as kind of a reference tool for clinicians and researchers, and then also just to identify areas within the research that could stand to be addressed further in the future. So I'll be going over 6 sections from my paper, starting with the introduction, which I'll just give some important background information and research that explains why this topic is important and relevant today. And then I'll be going into the body sections of the paper, which the first section is about how patients tend to be viewed differently based off their race from the viewpoint of the medical providers. The next section will look at how pain is assessed differently and pain treatment recommended differently by providers based on a patient's race. And the third section will be looking at how medical providers tend to recommend treatment differently for patients from different racial groups. And then after that, I'll look at potential solutions that have been brought up in the research. And then I'll conclude by just sort of summarizing the major takeaways and then identifying those areas which could stand to be researched in the future. So in the introduction, I talk about some of these studies that identify the need for this topic to continue to be addressed moving forward. And the first study I reference was a review of basically just the state of medicine in the United States in 2002, which showed that minority groups tended to receive fewer treatments and poorer quality care in general. And then a similar study almost a decade later showed essentially those same results for minority groups, which basically just shows us that the issue hasn't been resolved. The problems are still recurring, and so whatever solutions we have put in place haven't been adequate in resolving the issue. And the ultimate effect of this, there are direct effects as far as like what treatment differences there are for people of different racial groups, but it also has the effect of people from minority groups who perceive discrimination tend to be less likely to seek medical attention and adhere to directed behaviors from medical providers because of the developed distrust there is in the medical system, which of course has far-reaching effects for people's long-term health if they don't feel comfortable accessing health care. So moving on to the first section, where I talk about how patients tend to be viewed differently when they belong to different racial groups. A study in 1999 saw that physicians showed a significant difference in rating emotional, intellectual, and communication characteristics, as well as predicting negative behaviors between black and white patients. And so essentially, physicians tended to expect black patients, when compared to white patients, to not comply with treatment directions or to be more likely to miss appointments or to be hostile, and essentially just showed a preference for white patients and an expectation that they would be better behaved. And another study showed that physicians reported significantly greater liking for white patients than black patients, which is based off of an implicit association test, which is just kind of a standard benchmark used in psychology to assess preference often between two groups of people from different racial groups. And physicians also showed that they believe white patients would be more likely to cooperate with treatment in this as well. And then in the next section, I was looking at how medical providers tended to assess pain differently for people from different racial groups. And this first study saw that patients with the same long bone fracture injuries in ERs were significantly less likely to receive analgesic than white patients if they were black. And black patients were 66% more likely to not receive any pain medication when compared to white patients. And another study showed that medical students who held more false beliefs, and just as an example of some of these false beliefs that they looked at in this study, one of them was that black people have thicker skin than white people. Another one was that black people have stronger immune systems than white people. So medical students and residents who believed in at least one false belief, like the ones I just mentioned, also showed significantly lower pain assessments for black patients when compared to white patients. So essentially they believed that a black patient would experience less pain in the same scenario as compared to a white patient. And there was also, in another study, a significant difference in analgesic, or there was no significant difference in analgesic administration between black and white patients with an appendicitis, and this was specifically looking at children. And so this study contradicts most of the other ones I've come across, and shows that maybe there is an association there with age or potentially the type of procedure or condition being looked at when assessing pain. And so there might just be some important caveats within this argument, but the general consensus through research is that there do tend to be some differences in how pain is assessed and treated between black and white patients from medical providers. And so in the next section, I was looking at how other operations and the recommendations tend to be treated differently between black and white patients. And so one study I mentioned earlier found that black patients were significantly less likely to be prescribed cardiac catheterization, which is an important diagnostic and interventional tool for cardiac health, when compared to white patients by physicians. And this was independent of those same physicians' predicted likelihood of disease for these patients. Another study showed that medical students and residents who had more false beliefs, like the ones I mentioned earlier, were more likely to inaccurately recommend treatment to black patients versus white patients. And so those belief in anatomical myths essentially corresponded with a higher likelihood of misdiagnosing and mistreating a patient based on their race. And so this table up here is from that study about false beliefs that I was just discussing. And so if you'd like to pause and just look at some of the examples of these anatomical myths that they use in this study, and also like the percentages of people from different years of medical school and the residents they looked at, of percentages of those people who believed in these different myths. And so in bold you'll see anatomical myths that the anatomical myths that are false, and then unbolded is ones that are actually shown in research. And we're seeing that like there are pretty high levels of medical students and residents who do believe in at least one of those. There is actually a majority of medical students who believed in at least one of these, according to this study. And these beliefs, which are founded in the idea that race and biology are very closely intertwined, and that race predicts a lot of biological and anatomical features of a person. This idea isn't supported by research. In fact, most research shows the opposite of this idea. So for example, there was a study in 1972 which was looking at genetic variations between racial groups from around the world. And this study found that only 6% of variations between individuals could be statistically attributed to racial categories, and concluded that race is not a significant predictor of genetic traits. It can only be a significant predictor of about 6% of genetic traits, actually. And another study later in 2002 found that people from Africa were found to have slightly more genetic variation on average from other people from Africa than people from Asia or Europe, which is essentially showing that two people from Africa who would be ascribed to be within the same racial group in America would tend to be more genetically different from each other than either of those two people would be from somebody from a different racial group in America, which suggests this argument that race is not a biological feature of humans as it is often considered according to these studies in our society, and is actually just a social facet. And so the conclusion from studies like these are that, again, race is not a significant predictor of genetics in a person, but it's being prescribed a lot of significance in the medical community, as we're seeing with these false beliefs corresponding with differences in pain assessment and treatment recommendations. And these beliefs and corresponding treatment differences are not founded in scientific research and actually contradict the research that exists. And so a proposed solution to address racial bias in medicine involves essentially counteracting these beliefs in anatomical myths between racial groups, and teaching medical students and other future medical providers and already trained medical providers about these false anatomical myths that are prevalent within medicine and the general population. So a potential solution would be to essentially just try to eliminate those false beliefs to more accurately reflect the research out there, and that would hopefully eliminate some of the bias. There are also more direct interventions for medical providers that have been studied. One listed at the bottom involved a perspective-taking intervention, and they found that providers who received this intervention treatment had 85% lower odds of demonstrating a treatment bias against black patients a week after undergoing the intervention. And this was for providers who had shown a racial bias in their treatment already. And this was compared to a control group who had also shown that treatment bias. And essentially what this perspective intervention was they would give feedback to these providers in the experimental group about their bias and essentially talk to them about their bias and explain like what it is and what they did and how that constituted bias, and then also showed them videos showcasing how pain impacts the reality and the feelings of patients, just to kind of try to get them to see the perspective of the people they're treating and hopefully develop sort of a sense of empathy. And again, they found that treatment was fairly effective according to their results at reducing racial bias. So that's kind of two solutions I've been able to identify in the research so far. And to conclude this, essentially what I've found is just that racial bias manifests in a lot of different ways in medicine and can even look beyond the impact of medical providers to just social factors that are playing into this as well, like from an institutional perspective and just geographically, people of different racial groups may tend to not have the same access to healthcare. There's a multitude of factors like this that are playing into this, but just even within the medical provider's perspective, there's multiple ways that we looked at in this presentation that are playing into the detrimental effects to people from different racial groups as they access healthcare. So with the effects discussed, research shows that perceiving discrimination among minority groups is associated with seeking less medical attention, and it also has consequences for physical and mental health for these victims of discrimination. For example, hypertension tends to be higher, and there tends to be higher rates of depression and anxiety for people who are victims of discrimination. So not only are their treatments different, they also have these other effects associated with it as well. And for future research, there tends to be mostly focus on physicians. So I think it would be interesting to also do similar research to the ones I discussed with other medical providers, PAs, nurses, host of others. And I think it would also be beneficial to look at further intervention methods to resolve the issues, as most of the research tends to be about what the effects are and less of a focus on how to actually resolve them. And so I think shifting the focus a little there could help resolve the issue going forward. But thank you for tuning in today. Hopefully that was informational. If you have questions, obviously you can't ask them to me in person, but feel free to look up my name through Outlook and send me an email if you'd like, and I'll go ahead and show my references if you'd like to pause just so you can see the papers that I'm getting this information from. There's the second page. But yeah, that's all I have today. Thank you again for watching.